Don't go. So may I invite Dr. Vidhya? Yeah. So she's the oculoplastic surgeon. Okay. Formerly with Arvind Madurai. Huh? Now with Eye Foundation Coimbatore. Yeah. Yeah, it's a very interesting topic. Restoring the pathway, canalicular trauma management tips keynote address. It's a keynote address. So your time is 12 minutes.
Yes, sir.
Yeah.
Very good morning, and thank you KSOS for having me here and giving me this wonderful opportunity to talk on this topic. I took the liberty of modifying it a little bit. I'm going to be talking about both eyelid and canalicular tear management. So, ocular adnexial injury is a very common case scenario in our day-to-day practice, and we as ophthalmologists, we should know like adnexial injuries need proper treatment, because if we treat it properly, we can prevent lid notching, we can prevent exposure, we can also prevent ocular surface disruption, and we can address the aesthetic concerns of the patient, and we can also prevent the functional problems like canalicular stenosis and epiphora, which is very important. The basic principles remains the same, like we have to take proper history, very careful examination, and we have to prioritize our treatment plan according to our patient presentation. Detailed history should include the mode of injury, because that is going to alert us what we are dealing with. Like in case of penetrating injuries, we should be suspecting some kind of foreign bodies, both intraocular and intraorbital. You heard wonderful talks about that. History of fall, which can also cause globe rupture. Dog bite has got some kind of tweak in management, which I'll elaborate in the subsequent slides. Physical confrontation has got a potential medico-legal aspect, so that has to be remembered. So we have to have proper documentation of everything, and we have to document the facial photographs also. Injury with hooks, even the blouse hooks, which are very common in Indian subcontinent, and that should alert us to the presence of possible canalicular injury. So I talked about medico-legal aspects. The facial injury in general comes in grievous hurt. So we should document everything properly along with photographs. So that is very important. If you're going to be taking our patient under general anesthesia, again, time since last feed is very important, and systemic illness, so that we modify our treatment plan according to the presenting condition. Ocular examination, it's very important. We need to document vision in both eyes, specifically check for RAPD, and always rule out ocular injury and extraocular muscle injury. Radiology wherever it is indicated, and please document everything along with preoperative photographs. Any medial canthal injury, which is medial to punctum, specifically look for canalicular tear injury, either by direct observation or sometimes by probing. Grossly, any laterally displaced wound should alert us to the presence of the canalicular tear injury. So always prioritize your treatment plan. In case of head injury, priority is attending, of course, to patient's general condition. In case of globe rupture, the repair of globe rupture comes first, followed by lid tear repair. Many of these cases can be done under local anesthesia, but in case of children or wherever you have extensive injuries requiring long time to manipulate to repair, probably will be taken under general anesthesia or IV sedation. In case of canalicular tear, perilesional or infiltrative block can preferably be avoided, and we can just go for regional blocks like infraorbital and infratrochlear block. That's a preferred thing, so that we have less of tissue distortion. So I'm going to be sharing top 10 pearls in eyelid and canalicular tear management. The very first thing is thorough wound inspection. Always look for foreign body, because many of these wounds can have small foreign bodies embedded in that, and we should not be missing out those things. Sometimes the lid may appear apparently necrotic or devitalized, but potentially all facial structures has got high vascularization. It's not essential to debride excess tissue. And many of these lid tears appear little larger than what it is because of the unopposed action of the orbicularis. So that should also be kept in mind. And so this is the small foreign body which is in the wound. Okay, so moving on to the lid tear marginal repair, which is very important, because proper apposition is going to prevent the lid marginal notching. So what I'm showing you here is 3-1-1 technique. It's otherwise called far near pass. I'm taking 3 millimeters from the wound, 3 millimeter down, 3 millimeter the other side, 3 millimeter the lid margin, reverse the needle, 1 millimeter on all sides and tie your knot. At the end of tying the knot, it should be slightly everted. You can look at here, this is the marginal eversion, and leave the suture ends little longer. And take subsequent sutures and include this long end into your subsequent knot so that it doesn't abrade your cornea. So that is the thing. The suture material that I'm using, this is where I'm including the long suture end in the subsequent sutures. So that is very important so that we do not cause any abrasion of the corneal tissue. Right. So this is about the lid marginal tear repair, and the eyelid tears not involving the lid margin. If it is horizontal, it is like any other place, just suture it accordingly. Whereas if it is vertical, so in those cases sometimes if it is very ragged, we may have to convert that into a pentagon shape so that we have aesthetically more pleasing results. So this is a horizontal tear which I am repairing with interrupted sutures. But rest of the vertical sutures, make sure you excise the excess tissue and then go ahead. So that's about the tears not involving the lid margin. Moving on to the main topic, the decoding of canalicular injury. Any medial canthal injury, we should look for canalicular injury because it can be a result of direct and indirect injuries. And there are no tarsal supports there, so it can cause avulsion of the medial canthal area. So we need to identify that and treat accordingly. The critical factors in the management of canalicular tear would be the extensive nature of the injury and the site of the injury, whether it is proximal or distal. Proximal canalicular tear injuries are likely to have better anatomical and functional results compared to the distal ones, which is close to the medial canthal area. And it is also decided by the critical factors of another coexisting lid abnormalities and ocular abnormalities. And we need to plan our management depend upon presenting one or both canalicular tear involvement. And world over, now the canalicular tear management is with the use of stent, either monocanalicular stent or bicanalicular stent. So I'm going to be showing a video where I'm using a monocanalicular stent. The critical factors here or the essential steps here would be identifying the cut edge of the canaliculus. So first I'm doing a punctal dilatation. This is a 4-year-old child with a canalicular tear. I'm using a lacrimal probe. So usually the cut end of the canaliculus can be identified as a whitish tubular structure surrounded by the pinkish orbicularis tissue. So what is essential is that, let me pause this video. What is essential is that we avoid using perilesional or infiltrative blocks, go for regional blocks. That will distort your tissue lesser and you'll have a better view. So that is one thing. And avoid holding the tissues with a sharp forceps. Use always Q-tube applicators or cotton applicators. Use of vasoconstrictors also gives a blood-free field and proper visualization. There are many techniques to identify the cut edge of the canaliculus, like injecting visco, injecting dye from the opposite end, or use of pigtail probes, which is not preferred these days. But use of microscope with a higher magnification always helps. So that is something that we need to do. And what I'm using here is an oro stent. I do not have any financial interest in this. And I'm inserting that into the cut end of the canaliculus. And I'm going to fast forward this a little bit. Okay, so once this is done, this oro stent, this stent has got a longer tube and a collarette which sits in the punctum. So that can easily give you, almost you don't have to suture the end also. It is just that insert this and look at this, this collarette, it sits next into the punctum. So the insertion is that you can use either a probe to insert into the punctum, or sometimes you can just pull from the distal end. If it is very close, sometimes it can cause a punctal tear, so be very careful with that. So what I'm going to do is that I'm going to pull it from the distal end so that I secure it with the along with the punctum. So this is what I was mentioning. So just pull it out and leave it. Okay. So once this is done, securing and keeping it in place is by 2-3 methods. One, you can do an edge-to-edge anastomosis of the thing, which I'm doing it here. You can identify the cut ends and oppose it and give proper result, or sometimes just give a canalicular stitch, wherein you take a skin and orbicularis around the stent and keep it in place. That will also be helpful. So, once we are done with that, it's important that we keep the stent for at least for about 6 weeks. Stent removal is very easy, can be done in OPD, under topical anesthesia. Just use a forceps, identify the stent and pull it out. So it's as simple as that, doesn't require any other fancy equipment. So that's what it is. Another important factor is that if we carefully examine our wound and we find orbital fat, that should alert us to the presence of violation of orbital septum. If the same thing happens, this is the orbital fat in the lower eyelid, so that means there is some amount of orbital violation. If the same thing is there in the upper eyelid, that means we should explore LPS. That is an important finding that we should need to keep in mind. Do not suture the orbital septum because that can cause some kind of restrictive retraction of the eyelid. That's an important finding that we need to do. Many times patients present with irregular apposition, so they usually require reconstruction to have pleasing results. And dog bites require special mention because these are common in children. Copious irrigation, rabies prophylaxis, tetanus prophylaxis, and infiltrate the wound with local immunoglobulins and then go for primary repair. Systemic antibiotics are usually required to prevent wound contamination. Remember the complications like post-traumatic ptosis, pyogenic granulomas, medial canthal distortion. Sometimes you have this kind of abnormal eyelid with the potential exposure keratopathy. So remember these complications and try to do a good job. And it is time consuming, it is challenging, but it gives the most gratifying results like this. Meticulous repair is what is required in your lid tear management. Thank you so much for your patient listening. Thank you.
Thank you, Dr. Vidhya, giving us the elaborate management of a canalicular tear. Any question? We'll take one question here. Please be here. Yeah, I think we'll have one question. We've got 5 minutes time. So one question each to each speaker. Any audience would like to ask? So I think the canalicular tear is very common in day-to-day practice. It varies from child to elderly people. So is there a management difference between the elderly person and the child? Only except that it should be done under general anesthesia for children?
No, sir. Some case of children will have a smaller punctum. So you have to dilate the punctum and go ahead with that. So sometimes if you over dilate that punctum in children, it can cause extrusion of the stent. So that is one potential complication that can be there. The same goes in for adults also, like the puncta may be patulous. So if you put in the stent, sometimes it can go inside, migrate inside, and that can be a problem. So those are the two differences.
Do you think the stent is a must in all cases?
Absolutely, sir.
Huh?
To have
in all cases of canalicular tear,
yes,
you should
whether it is upper, lower, both, always use a stent.
So you should have stent with you
all the time, sir.
Yeah, practice.
Yes, sir.
Okay. So, yeah.
Very nice presentation.